Thank you very much to everybody to being here. For me, it's a great honor to present the National Institute of Pediatrics in Mexico, the Division of Pediatric Pulmonology. I want to introduce Dr. Adriana Alva Chaire, who is the Associate Professor at that institution, who will present a clinical case with Karen González and Melissa Iglesias, who are the Senior Pediatric Pulmonologist Fellows at the INP. Thank you very much, Dr. Adriana Alva, for accepting to present this clinical case.
Thank you, Laura. Hello, everyone all around the world. Laura has already introduced me. I am a pediatric pulmonologist member and professor associate of the Pediatric Pulmonary Department at the National Institute of Pediatrics, which is a national referral tertiary center located in Mexico City. Thank you for the invitation to this virtual International Pediatric Pulmonary Network clinical case series. The main presenters will be our senior pulmonologist fellows, and afterwards I will summarize the relevant information available so far of this rare and unique entity. Let's get started. The title is Anti-MDA-5 Dermato-Pulmonary Syndrome, 2 cases, different outcomes. These antibodies, anti-MDA-5 associated dermatomyositis, is one of the deadliest and severe interstitial lung disease phenotypes in the idiopathic inflammatory myopathies when present. Initial respiratory manifestations are mild or even absent. Early and aggressive treatment is imperative then, and early recognition is paramount. Knowledge of these unique mucocutaneous disease features may be the clinician's first clue to diagnosis for the disease. We were going to present the first case.
Hello, my name is Karen González, and I'm going to present the first case that is a 2-year-old female with no past medical history. The initial presentation was asthenia, anorexia, fever, heliotrope erythema, and Guttron papules. The evolution of this patient, she started on July 2023 and with fever and went to the doctor and was diagnosed with pharyngitis and treated with antibiotics. 2 days later, she presented with heliotrope erythema. And 10 days later, she had stomatitis, erythema, and ischemia in the diaper area. On August 10 of the same year, she persisted with intermittent fever, bipalpebral edema, and papules, and was treated again with antibiotics. 20 days later, because of the lesions she presented on skin and the persist of the fever, she was referred to the dermatologist and suspected of dermatomyositis and referred to this hospital. At her arrival to this hospital, the initial presentation was at her physical examination. She had the bipalpebral edema, malar erythema, erythematous nodules in hands and feet, the mild proximal weakness, and no respiratory symptoms. She had an SpO2 of 96% without supplemental oxygen. The first laboratory we had is a blood count that was normal and an elevated erythrocyte sedimentation rate, and the first chest X-ray that was interpreted like normal. She required of a multidisciplinary evaluation. A neurologist said she was asymptomatic and didn't require any further evaluation. On the cardiology, she had a normal electrocardiogram, and dermatology suggests the skin biopsy because of the erythema and heliotrope, the Guttron papules, and the malar erythema. She was admitted to the immunology department, and they request the next studies, muscle enzymes, antibodies, and immunoglobulins. This is the first chest X-ray we had on September 11 that she arrived to the hospital that was normal. And her first chest CT that was on September with right lung with slight hyperinflation and left with multiple segmental atelectasis, and the thickening of the peribronchivascular pulmonary interstitium is observed. The patient had no evidence at the time of self-immunity profile. However, due to a fever of 5 days of evolution and a biochemical data suggestive of an infection process, it was important to rule out this. Another of the suggested differential diagnosis was missed. This to the presence of fever of more than 3 days of evolution, history of diarrhea of more than 3 days of evolution, and the inflammation markers that was elevated at the moment. And the last option was dermatomyositis due to the presence of weakness in the lower limbs and lesions similar to the Gaucher nodules. That because of the suspicion of incomplete Kawasaki, she received treatment with gamma globulin 2 grams kilogram, hydroxychloroquine, and methylprednisolone 1 milligram kilogram day, plus she had prophylactic antibiotics at that moment. The next day, she started with low saturation at 88% and required supplementary oxygen. We received the report of the skin biopsy that said endermis superficial perivascular inflammatory infiltrate with lymphocytic predominance that was compatible with dermatomyositis. And 4 days later, we received the myositis antibodies that report highly positive for anti-MDA-5 and intermediate for anti-Rho52 that are related to rapidly progressive interstitial lung disease. That's the reason, because of the suspicion of this rapidly progressive interstitial lung disease, that she started treatment with methotrexate and cyclosporine. Due to the interstitial lung disease associated with dermatomyositis, we performed a bronchoscopy with bronchoalveolar lavage that was negative to bacterial, fungal, and mycobacterial culture. Because of the clinical evolution of the patient, in which at the beginnings of October, she started with tachypnea and tachycardia and increasing supplementary oxygen, it was suspected she had a lung damage progression. So immunology decided to add to the treatment mycophenolate and methylprednisolone pulses. And she had already been with immunosuppressor treatment, so a lung biopsy was needed to determine with precision the diagnosis that was performed on October 13 of 2023. Due to the clinical characteristics of the patient, early age of presentation, skin, pulmonary, and hepatic involvement, intermittent fever, the possibility of immunity is considered, particularly of autoinflammatory syndromes. At this time, we have the evidence of the positive antibodies, so immunology decided to add rituximab to her treatment. We have the result of the lung biopsy that was discussed at the moment. The first histopathological findings was extensive areas of hemorrhage, presence of abundant intraalveolar foamy macrophages, without the presence of microorganisms, without fibrosis, and without vascular affection that was compatible with autoimmune inflammatory process. But the final report was mild interstitial pneumonia with predominance of T lymphocytes, focal bronchiolitis, and endogenous lipopneumonia. We perform a full body S3 magnetic resonance that detect mild muscle inflammation and show active myositis at that moment. The first image, we can see the diffusive intensities in thickness of the intercostal gluteus minor and middle muscles in a symmetric form. The second image, we can see the diffusive intensities in the supraspinatus, infraspinatus, subscapular muscles with left pleural effusion. And the third image, we can see the leg muscles of the hip compartment. The next step was the CT chest that was performed on November to see the progression of the disease of this patient. And we can see the increase of the multiple areas of subpleural consolidation and ground glass opacities. At this moment, the treatment was methylprednisolone pulses 3 times, gamma globulin 4 doses, and rituximab 4 doses. On this timeline, when she arrived to the hospital on September with elevated inflammation markers, she had only oxygen to 0.5 to 1 liter per minute, and she received treatment with gamma globulin, hydroxychloroquine, methylprednisolone, methotrexate, and cyclosporine. On October, she started with progression of the respiratory symptoms. She had oxygen to 10 liters per minute, and she received treatment with methylprednisolone pulses, mycophenolate, and she has cyclosporin, but was suspended because of the side effects. And on that month, she received 1 dose of rituximab. On November, we can see the decrease of the inflammation markers, and she had 3 doses of rituximab and was on oxygen weaning. The post-discharge curse, she was discharged with supplementary oxygen after 80 days of hospitalization, wean off oxygen on April 2024. We saw her on March 2025, she was asymptomatic, and she's been on follow-up for 16 months with no relapse. The actual treatment is mycophenolate, hydroxychloroquine, gamma globulin 2 times per month, and she went off a steroid on August 2024. She has no any lung function test because of the age of the patient. And we can see on this image the mark she had of the Gottron papules. And the last CT chest that was performed on March 28 of this year. And we can see on only 5 of 6 critical bands. But we notice a huge difference from the last CT chest that we have from November of 2023.
Hello, my name is Melissa Iglesias, and I will be presenting the second case. This is a 6-year-old male patient with no previously comorbidities. His initial presentation includes fever, facial erythema, recurrent airway infection, and joint papules. He was previously treated with vitamins and tacrolimus. His main chief complaint upon arrival was that he had been experiencing these symptoms since 2021, and just before his hospital admission, he presented with weight loss, mild muscle weakness, joint pain, epistaxis, and bleeding gums. It can be highlighted that despite the patient meeting Bohan and Peter diagnostic criteria with typical skin lesions, mild muscle weakness, and elevated muscle enzymes, the diagnosis of dermatomyositis was not made, and his disease progressed with systemic involvement and bleeding. This is a summary of his evolution over time. He started on June 21st with intermittent fever and upper airway infection, which were treated with antibiotics. 3 months later, cervical dermatosis and malar erythema developed, and another medical evaluation prescribed only vitamins. 2 months later, joint papules appeared, and he was diagnosed with atopic dermatitis and started on tacrolimus with partial clinical improvement. 1 month later, symptoms remission was achieved with fever. However, fever reappeared on February 2024 after another upper airway infection. And weight loss, malar rash, another upper airway infection, inguinal and axillary lymphadenopathy, and joint pain developed. 2 months later, he had proximal muscle weakness and elevated muscle enzymes. Finally, 1 month later, he had epistaxis and bleeding gums and sought medical attention at our institution. Upon hospital admission, he was hemodynamically stable with low-grade fever, epistaxis, bleeding gums, malar rash, axillary and inguinal lymphadenopathy, and Gottron papules. These symptoms were noted as red flags. The multidisciplinary assessment first impression were as follows. Oncology, request a malignancy workup with lymph node biopsy. Immunology, suspect mixed connective tissue disease, lupus erythematosus versus dermatomyositis, and ordered inflammatory markers and autoimmunity panels, tests for cellular and humoral immunity defects, and evaluation for infection causes. Dermatology performed nail-fold capillaroscopy, noting telangiectasia and two dilated capillaries, a pattern consistent with dermatomyositis. Cardiology and ophthalmology evaluation were normal. Clinical progression and workup results, hypocomplementemia, hypergammaglobulinemia, and increased inflammatory enzymes were detected, along positive ESR and ANA. In the full body MRI confirmed mild active muscle inflammation of the posterior compartment, elbow folds, and latissimus dorsi. These findings were suggestive of dermatomyositis, so he was started on gamma globulin. After the lymph node biopsy, he requires supplemental oxygen and continued to experience intermittent fever. The lymph node biopsy ruled out malignancy. He received the first methylprednisolone pulse at 30 milligrams kilograms per dose and continued on an immunomodulator with hydroxychloroquine. He experienced clinical worsening with respiratory distress, and chest X-ray showed a diffuse alveolar patterns. The diagnosis of hospital-acquired pneumonia and anemia normocytic normochromic was made, and he was started on cefepime. Despite negative PCR panel for hospital-acquired pneumonia viruses, blood cultures, and C-reactive protein. It is a notable upon arrival, his chest X-ray was normal despite increased inflammatory markers, and his hemoglobin levels were also normal. At the time of respiratory distress onset, a diffuse alveolar pattern appeared and his hemoglobin levels dropped, despite mild reduction in inflammatory markers after the methylprednisolone pulse. The lung HRCT showed bilateral subpleural multisegmentary alveolar consolidation, air bronchogram, and bilateral ground glass opacities in these areas. The 30th of May, he showed rapid ventilatory deterioration requiring invasive mechanical ventilation. Vancomycin and gamma globulin were added. The ICU diagnosis was septic shock and anemia, requiring blood transfusion. Meropenem, trimethoprim, sulfamethoxazole, and voriconazole was added. A second PCR panel for hospital-acquired pneumonia, PCP, and procalcitonin was again negative. One day later, the myositis antibody report was highly positive for anti-MDA-5 and intermediate for anti-RO52, both of which are related to rapid progressive interstitial lung disease, and cyclosporin was started. The interstitial lung disease associated with dermatomyositis and the need to exclude infection etiology, bronchoscopy was performed, showing abundant mucus secretion and increasing blood return in the serial lavage aliquots. Bronchoalveolar lavage revealed foam cells, hemosiderin-laden macrophages, and no bacteria or fungal growth. The final diagnosis was diffuse alveolar hemorrhage. At this point, he showed clinical improvement, and extubation was positive despite the continued need for blood transfusion. On the 10th of June, he had a third episode of progressive ventilatory deterioration associated with anemia. He was treated with vasoactive agents, gamma globulin, and a pulse of cyclophosphamide. Plasmapheresis could not be performed due to hemodynamical instability. Despite negative cultures and biomarkers, hyperisoline, tazobactam, colistin, IV and nebulized, levofloxacin, linezolid, caspofungin, and teicoplanin were escalated. He had two more episodes of respiratory distress with diffuse alveolar opacities and anemia, requiring blood transfusion, and the second methylprednisolone pulse at a 15 milligrams kilograms per dose. In the last 4 days before his death, he had progressive refractory hypoxemia The oxygenation index was in 36, spontaneous pneumothorax, progressive increase in inflammatory markers, no response to high-frequency ventilation, and air leak syndrome. Finally, he developed hemodynamic instability, bradycardia, and cardiorespiratory arrest. Death is declared. In this graph, show the severity markers for lung damage despite an increase in immune suppressive treatment. The autopsy revealed lung with diffuse alveolar damage in the exudative phase, characterized by hyaline membranes in the alveolar sacs, interstitial and intra-alveolar edema, and alveolar collapse. There was epithelial change with denudation and macronecrosis of type 1 pneumocytes associated with hyperplastic type 2 pneumocytes. Vascular change include endothelial cell necrosis, neutrophil aggregation, sporadic microthromboembolism, and hemorrhage. Skeletal muscle examination showed mild inflammatory myopathy with perivascular atrophy and segmental necrosis of muscle fibers. Systemic lupus erythematosus was ruled out. Thank you.
Thank you, Veros. Well, the background of this disease, this deadly disease, is well recognized in the adult population. Anti-MDA antibodies were first identified in Japanese patients with clinically amyopathic dermatomyositis in 2005. MDA positive are present in 10 to 30% of all DM patients, and they have an increased predilection in Asian population. But they have been reported all around the ethnicities. Unique mucocutaneous manifestations may be due to the underlying vasculopathy. Hallmark is the cutaneous ulcerations and mild muscular involvement. The interstitial lung disease is present in almost 100% of the Japanese patients and East Asian patients, to 42% in the US and European cohorts. They may develop features of ILD associated with classic DM, with low progressive and with a relapsing and remitting course. And on histopathology, they have non-specific interstitial pneumonia or organized pneumonia. But they may also develop this life-threatening, rapidly progressive subtype of ILD with high mortality rate, with bilateral ground glass opacification or consolidation on HRCT, and on histopathology with diffuse alveolar damage and microangiopathy. The mortality rate has been reported from 40 to 60%, and it is much more higher in the Asian population. They have worse outcomes when they have concomitant presence of anti-Ro52 antibodies. In children, this entity is quite rare. Idiopathic inflammatory myopathy, it's a rare, have a rare presentation in pediatrics. 80% of the patients have dermatomyositis. The annual incident rates are of 1.9 to 4.1 per million children per year in the US and the UK. Triggers, the most popular triggers in genetically susceptible children are environmental factors, including ultraviolet B, medications, and infectious agents, such as parvovirus, B19, Epstein-Barr virus, Coxsackie virus, human immune deficiency virus, Mycoplasma pneumonia, and Toxoplasma gondii. And the muscular specific antibodies are detected in 70 to 80% of them. These myocytic specific autoantibodies were recently discovered, are a class of recently discovered markers associated to a unique clinical subset of myositis, and are therefore of great value in the classification of the disease. Assessment of the prognosis and formulation of treatment plans. They are found almost exclusively in patients with myositis and are considered to be mutually exclusive. There are other kind of myositis-associated autoantibodies that are present in patients with not just myositis, but also with other autoimmune connective tissue disease like lupus erythematosus and systemic sclerosis, and frequently co-occur with the myositis-specific autoantibodies. These myositis-associated autoantibodies have been found to be associated with older ages at onset and myositis overlap diagnosis, which represent a challenge for the clinicians and the immunologists, and that's why the second patient was in the second case was the differential diagnosis was lupus. Concurrent inflammatory myositis or SLE myopathy is present in 6.3 to 7.3% of the patients in the US studies. And this also the specific and the associated autoantibodies were present in 40% of the children, and difficult to classify muscle symptoms as manifestations of lupus or idiopathic inflammatory myopathies. What is known about interstitial lung disease in juvenile dermatomyositis is an early feature associated with mortality. The frequency goes from 8 to 30.9%. Children with respiratory symptoms to ILD screening have the necessity to screen for the specific myositis antibodies because it's helpful for early diagnosis of an underlying juvenile dermatomyositis. Screening for ILD also using the pulmonary function test seems sensitive, but it's not specific. Many times they have abnormal function tests and they are asymptomatic, and sometimes they have a restricted lung disease with the DLCO is low and they don't have any chest abnormality. So we have to do them, but also HRCT is needed. Most of these AILD cases, particularly in East Asia, are positive to the MDA antibodies, and incidence of the rapidly progressive disease of ILD leading to death is much more lower in children. When these kind of childs have abrupt deterioration of respiratory failures, it suggests complications such as pneumothorax or pneumomediastinum as our second case, which may develop secondary to ILD or the vasculopathy that this second case also had. What are anti-melanoma differentiated isostate gene 5 autoantibody? This is a sensor of viral double-strand RNA that induces type 1 interferon. The sensitivity is 77 and specificity is 86% for rapid progression interstitial lung development. And so early clinical diagnosis is essential, particularly because this anti-MDA antibody testing is not available in most centers. What do we know about anti-MDA-5 rapid progression lung disease? Sorry. Oh, no, sorry, I lose this. Juvenile dermatomyositis anti-MDA phenotype resembles the adult presentation. The median age of onset is 7 years, with between 6 to 13 years. That's why in the first case, immunologists had the suspicion that he didn't have the disease and was looking for other interferonopathies that explained the interstitial lung disease and the hemorrhage. Lower creatinine kinase levels and more mild muscle disease are seen. They have also the ulceration. They have arthralgia and symmetrical arthritis of small joints of the hands, with systemic features like fever and weight loss. And although laboratory and radiological evidence of myositis, myositis can be present. So even if they have a very mild muscle disease, the myositis, as you have already seen in the MRI, in the full body MRI, it can be present. ILD detected by HRCT or PFTS are frequently asymptomatic, and the interstitial lung disease are seen in between 50 or 30% of the patients, with rapidly progressive ILD leading to death in much more lower percentage as in adults. The anti-MDA-5 rapid progressive ILD is defined as the definition in adults as a progressive interstitial lung disease within 3 months of the onset of the respiratory symptoms. They have a lower 6-month survival rate of about 57% and decreases and have a decreased rates in concussion. This is a hypothesized pathogenesis in anti-MDA-5 dermatomyositis ILD. The MDI protein can recognize viral double-strain RNA that activates the interferon 1 pathway. This activation system promotes the production of MDA and causes an MDA overexpression. And there's then an abnormal accumulation of MDA protein that may lead to loss of immune tolerance, resulting in the production of anti-MDA autoantibodies. And these ones may potentially contribute to the pathogenesis through binding the MDA on the cell surface or on cell or forming immune complex and interacted with cytoplasmatic MDA. In the lungs, the CX3CL1 can be produced by endothelial cells when exposed to interferon 1 and induce a recruitment of alveolar M2 macrophages. And then the local productions of TGF-beta by the M2 macrophages that directly promotes pulmonary fibrosis. Also, there's another set of T cell subsets here with the CD positive CXCR4 positive T cells in anti-MDA and can produce also fibrotic agents like TGF-beta, alpha, SMM, collagen 1, and interleucin 21. The process activates also the nets and this neutrophil releasing and could expose more MDA autoantigens. Okay. Which patients have worse clinical outcome? The Asian, but it has also been noticed in Black or Hispanic, and the combination of positive anti-Rho52 and anti-MDA antibody should alert clinicians for close monitoring of pulmonary complications. Also, at the bench side, elevated CRP and KLC levels, ferritin, LDH, or ALT could be used for monitoring and for progression. Which is the treatment? However, there is no high-level evidence supported by controlled study on the treatment of this disease, possibly because of the rarity of the disease. Thus, the treatment mainly apply the therapeutic strategies derived from other studies on adults patients with dermatomyositis to the pediatric patients. Although interstitial lung disease complicates 50 to 80% of these patients. Most cases do not progress rapidly and respond to high dose of glucocorticoids combined with either a calcineurin inhibitor or IV cyclophosphamide. It is often difficult to predict the rapid progression of the interstitial lung disease at initial presentation, as you could notice in our cases. The Japan group uses a triple combination regimen, says that should be initiated in patients with dyspnea, diffuse or multiple ground glass shadows on initial CT, or high levels of anti-MDA autoantibodies. Also, this regimen should be commenced in cases of interstitial lung disease progression with 1 or 2 weeks despite the high dose of glucocorticoids combined with either the CNI or the IV cyclophosphamide. And also, it's useful to eliminate the autoantibodies and autoantibody producing B cells. This could contribute to remission in refractory disease. This is one of the clinical practice guidelines for juvenile dermatomyositis update. As you can see, most of the treatments are related to the other manifestations of the disease, and they only says that when you have HRCT and you have interstitial lung disease, you should diagnose the possibility of infection, and concomitant therapy for infection should be started. And after that, the patient has to have pulses of methylprednisolone, has a therapy with the calcineurin inhibitor, cyclophosphamide, or both. And if it's effective, they can continue just reducing the glucocorticoid. And if it's not effective, you have to add all other that recently has been demonstrated that they are useful, like mycophenolate, rituximab, the plasmapheresis, and recently the anti-JAK treatments. This is one case that can exemplify. We didn't have the photographs of the skin of our patients, but this case exemplifies the cutaneous abnormalities with the cotron papules, and also the hyperpharyngeal hyperpigmentation, the dactylitis, and the skin ulcers that sometimes are called inverse cotron papules. And also they have in the joints also, no? This girl is a 16-year-old Chinese female that presented with fever and cough for only 1 day, and finger swelling for 3 weeks. She already had interstitial lung disease at the presentation that they missed, manifested as cough and opacity in the chest radiograph, which later was confirmed by the tomography. And what is the other radiological sign that is important is the presence of the pneumomediastinum. She was treated accordingly to the adult guidelines with steroids, and at the initial therapy, you can see all the intensive care at the beginning, no? And they were using the inflammatory markers, ferritin, CK, and ALT. And after this first treatment induction, she had relapse. And but suddenly she had another flare of the disease, so they decided that the initial therapy was not good, and she was put on rituximab and cyclophosphamide. With that, she didn't require any other treatment, and the follow-up for many months. You can see how she had only the marks as in our patient of the Grotron marks, and only the hyperpigmentation of her fingertips. The refractory disease is much more difficult to treat in the sense that most of these patients are only a few cases in every cohort. So they have been using rituximab, JAK inhibitors, elimination of the autoantibodies, extracorporeal membrane oxygen, that at first is just as a bridging point for lung transplant, but there's a case that was used with rituximab, and after 45 days of ECMO, she could be weaned from that, and she survived. Lastly, my final thoughts is that interstitial lung disease in myositis can be a deadly complication, and it's often under-recognized, leading to the potential delays in diagnosis and treatment, as in our second case. The first case was rapidly diagnosed and rapidly was put on the right treatment, and that's why she had a very good response. Anti-MDA-5 associated juvenile dermatomyositis poses diagnostic and management challenges due to its rarity, atypical presentation, and poor prognosis. And early screening for pulmonary manifestations allow a window for aggressive treatment to avoid progression to rapid ILD. And also, we need more studies because there is a lack of well-defined and individualized treatment strategies. And although rapid interstitial lung disease remains the major cause of death today, its outcome has improved with early diagnosis and intervention using a multi-drug regimen. Thank you. We are ready if you have any comment or question.
Thank you very much to all the team for this excellent presentation. Very interesting. What is the survival of these patients, even though we could make the diagnosis early?
Less than more than 50%. Well, but there are not many courts addressing that, and they also don't because they don't have all the antibodies or the lung biopsy. It sometimes could be the confusion with the other ILD related mixed connective tissue disease. It's something that doesn't permit to know that.
Okay. Yes, very rare. I have never heard about it. Well, I don't know if somebody else in the audience has any question. Okay, no, thank you very much. It's what they said. There is a question from Pilar de Mirel. Says that what is the youngest age for RP-ILD seen?
I think it's the two patients. One is ours, and another one was a 2-year-old girl that had also very mild respiratory disease. She has the ulcerations in her ear and also had pulmonary hemorrhage, and she was 2-year-old and she survived.
Yes, it's very interesting that the ancestry you talk about is from Asia mainly, that you have 2 patients here.
Yeah.
Okay. Okay, so I think there's no more questions. So thank you very much, Dr. Adriana Alva, again for sharing this with us. And next month on May, we will go to the ATS. I hope most of the people that are connected will be there. So we don't have clinical case. So our next clinical case will be in June. So we will share with you the link. And thank you very much, Samantha, for helping us with all of this.
Thank you very much for the invitation. See you.
Thank you. Bye-bye.
Bye.